papillary thyroid microcarcinoma, micro itself is less than 10 millimeters. And any lesion which is less than 1 centimeter will be non-palpable. So obviously less than 10 millimeters non-palpable is referred to as papillary microcarcinoma, which is again less than 10 millimeters non-palpable. This is the correct option. 5 no, less than 10 palpable no, less than 5 again it's no, right? So it is A for Ahmedabad. Remember a debate on papillary microcarcinoma, that is whether to operate or not. Remember, in these patients, majority of them, in fact, it is also seen post-autopsies, right? So what I'm trying to tell you is patient would have a natural cause of death and the malignancy should remain dormant inside. So observation is a viable option in a microcarcinoma when compared to surgery. Now this holds pretty strong for elderly patients for obvious reasons, right? Patient already, let's say in his 60s or 70s, and you detected a papillary microcarcinoma, there is no need to operate. You wait, because majority of the microcarcinomas, or I'd say the micropapillary carcinomas, they remain silent within the thyroid gland itself, right? So this is with respect to question number 30. Okay, let's go to question number 14. On endoscopic ultrasound, EUS is endoscopic ultrasound, esophageal leiomyoma, the most commonly appears in which layer? Okay, so this is a question associated with layers on endoscopic ultrasound. So when you look at the endoscopic ultrasound, you will go through various layers that you have, right? The first thing that you will see, a solid compartment. This is your endoscope. Then you will have a very thin compartment which is even huge. So this is the esophageal balloon that we have, right? So the two concentric rings, see, this is a very thick and a very, I would say, a discrete ring that you will see on an image, and then you have a very thinned out, that is nothing but your esophageal balloon, which is very thin. After that you have the first layer. After that you have the first layer. Remember, the first layer is referred to as the mucosa, and the second layer beyond mucosa is called as the deep mucosa. So this is mucosa and this is going to be considered as deep mucosa. So layer number 1 and layer number 2 are mucosa and deep mucosa. Then you have layer number 3 on an upper, that is endoscopic ultrasound. This is layer number 3 and this happens to be your submucosa. Majority of your pathologies are present in submucosa. Then you have the last layer of the esophagus which is present. That is nothing but is your muscularis layer. This is it, layer number 4, that is muscularis. That is nothing but your muscularis, right? Now, leiomyoma presents in which layer? As we all know, leiomyoma can arise from layer 2 and layer 4 both. It can arise from layer 2 as well as layer 4, but most commonly it arises from layer 4. Now let's look at what can arise from the various layers. So that is the first and the second layer. What do we usually have? The most commonly we see is presence of esophageal retention cyst. The most common site for esophageal retention cyst is layer 1 and layer 2. When we talk about the third layer, in third layer we usually see the lipoma of the esophagus, the fibroma of the esophagus, the neurofibroma of the esophagus, right? In layer 4 we see the leiomyoma of the esophagus. As I told you, in layer 2 we can also see leiomyoma, but most commonly the leiomyoma is seen on fourth layer. It is seen on the fourth layer, right? So answer is going to be 4. That is D for Delhi. Chale, let's move on to the next question. That is question number 15. Okay, slightly bigger question, NEET pattern. We have 27 years old male patient. So we have 27 male, known case of Crohn's disease, right? With already several extraintestinal manifestations of Crohn's, including erythema nodosum, that is skin, arthritis, bone, ankylosing spondylitis, bone, anemia, blood, episodes of pancreatitis abdominal. During the evaluation of his right lower quadrant pain, he is found to have a segment of a thick ileum causing obstruction. Which intestinal manifestation of Crohn's disease would you not expect to subside after resection of the involved small bowel? Remember, ankylosing spondylitis, it is not going to resolve post surgery. That is what I remember, right? So rest everything will resolve back except for ankylosing spondylitis. Now, if you talk about the extra intestinal manifestation, for Crohn's disease can be divided into one that presents in skin. For skin, we have erythema multiforme, erythema nodosum, pyoderma gangrenosum. Erythema multiforme, erythema nodosum, pyoderma gangrenosum. For eye, your ophthalmologist will tell you it has all three inflammation, that is iritis, uveitis, and conjunctivitis. These are the external manifestation eye. For joints, we have peripheral arthritis, presence of peripheral arthritis, number one, and ankylosing spondylitis, which does not recover or revert post surgery. So this is persistent. With respect to blood, I already told you there is anemia which is present. So anemia is another factor. With respect to kidneys, two important things. One is nephrotic syndrome. Another one is amyloidosis. Nephrotic syndrome and amyloidosis. With respect to pancreas, we just had the patient with pancreatitis. This summarizes presence of extra-intestinal manifestation of Crohn's. Remember, ankylosing spondylitis do not revert post-surgery. Do not revert post-surgery, right? Okay. Let's move on to the next question. Question number 16. Okay, now we have, now we have MAG, that is mercaptoacetylglycine 3. In fact, MAG is considered to be the gold standard for renal perfusion, right? Currently, MAG is considered to be the gold standard for renal perfusion. The gold standard for renal perfusion. The other variant that we have is DTPS scan, that is diethyltryptamine pentacetic acid. Now we have MAG scan, which is present for two kidneys, and we have to see what is wrong and where, right? Definitely they are not, I would say, normal scans, because you can see right and left kidney marked here. This is your left kidney, this is your right kidney. You can see both of them are different graphs. So something is wrong. Now what happens is MAG, that is nothing but a radioactive dye that we give, or I can say radiolabeled dye, which you inject into the peripheral veins. From there it goes into the kidney, and in the kidney it will have a rapid uptake. It will go into the kidneys, it will be processed, and it will start excreting. It goes into your calcium system. From the calcium system, it goes into the ureter. From the ureter, it escapes out, and the dye is excreted out of the kidney and will fall. This is a normal MAG scan. So left kidney is normal. What is happening in right kidney? Again, in the right kidney, the uptake is normal. The kidney is taking it. Now it has reached the calyxes. From the calyxes to the ureter, it is not going, right? It is retained in the kidney, it is retained, but after a while you will see that it starts to go down. That means it starts to excrete, but it's taking a very long time to excrete when compared to the conventional one, right? So I can see in the right kidney there is some sort of an obstruction. It is definitely obstructed. Now when I'm talking about obstruction, is it a complete or partial? Because if it was a complete obstruction, it would have retained. So the graph will continue to flow like this. But as it is coming down, that means it is excreted. I would say it is partially obstructed, right? So left is normal. So we have two options, B and C, where left is normal. Right is completely obstructed, right is partially. As I can say, it is correct as partially obstructed. So the answer is going to be D for Delhi. The answer is going to be D for Delhi. That is for question number 60, right? I hope everybody is clear. Chale, moving to the next question, question number 17. Okay, we have a 63 years old female, unresectable cholangiocarcinoma. They only told don't operate cholangiocarcinoma. You're already on palliative management, right? Now patient has fever, right upper quadrant, pain, jaundice with cough for 1 day. Okay, Patient is having fever, tachycardia is present, blood pressure is normal, respiratory rate is slightly high, saturation is okay. Now physical examination shows a soft and a non-distended abdomen, tenderness in the right upper quadrant, and hepatomegaly. So liver is enlarged, right? Now lab result says the total count is elevated, 4 to 11 is normal, the ALP is elevated. Again, the chest X-ray shows an elevated right hemidiaphragm. Obviously liver is enlarged, the diaphragm will be pushed upwards, right? And lower lobe atelectasis. Ultrasound performed shows a round hypoechoic lesion within the liver, with well-defined borders and several internal echoes. My catch point here is presence of internal echoes. Presence of internal echoes indicates infective material or infective collection, right? Mildly dilated intrahepatic ducts, no cholelithiasis or pericholecystitic fluid. In addition to further imaging, what is the most appropriate management, right? Now let's see what is the case. This is the liver. These are the bile ducts. This is the cystic duct. This is the gallbladder. This is the common bile duct. It opens into duodenum. Let's just say this is the duodenum that we're talking about, right? And let's say this is the pancreas that is present along with, and this is the pancreatic duct. Together it fuses and opens into the duodenum. Not worried about it. Now I'm saying there is already a cholangiocarcinoma, distal cholangiocarcinoma present. Now what this distal cholangiocarcinoma is doing, it is not allowing the bile to flow properly. So obviously there will be stasis of bile. Now this stasis of bile is I would say a nidus which will allow the infection to go upwards, usually ascends into the right side of the liver and forms an abscess here. So it is a case. See, there is a nidus of obstruction. This obstruction is present in form of cholangiocarcinoma. There is stasis of bile. Infective collection, that is on ultrasound. I have presence of internal echoes which are present here. Presence of internal echo says it's an infective fluid. There is fever, obviously it goes with infection. There is tachycardia, again it goes in favor of infection, right? So this looks like a case of pyogenic liver abscess, right? Pyogenic liver abscess. The most common organism for pyogenic liver abscess is going to be E. coli and Klebsiella, right? Now, what do we do for pyogenic liver abscess? What is the management, right? The management is you have to take out the pus, that is collection which is in the liver, and put the patient on antibiotics. So it's asking for most appropriate management. The most appropriate management would be percutaneous drainage and IV antibiotics. That is option B. Antibiotics alone will not help. ERCP won't help. It will only facilitate. Obviously, if the option for this entire case would have been, that is percutaneous drainage plus antibiotics plus ERCP stenting, then I would say this would be a better option, but this is not there. So we only have drainage and antibiotics. Laparoscopic cholecystectomy, there is no cholecystitis and there is no stones in gallbladder. It was not the gallbladder causing the problem, right? So no need to remove it, of course, right? So it is D, that is D for Bombay. Percutaneous drainage and IV antibiotics. Sorry. Move on to the next question, question number 18. Again, we have a 58 years old woman, elderly female, jaundice. ERCP was done as a part of workup. The radiograph shows what is the most likely diagnosis. Let's look at the most likely diagnosis. Now, this is your endoscope. This thick one is your endoscope. This is the, I would say, the guide wire that you have pushed, and with the help of this you will be putting the dye as well. Now what is interesting here is you have one duct which is present here, another duct which is present here, right? This is called as the double duct sign. Double duct sign and inverted 3 sign. Inverted 3 sign. This is mostly seen on a cross-sectional image, but double duct sign, inverted 3 signs are characteristic of pancreatic head cancer, right? So this image goes in context of favor of pancreatic carcinoma. It's a double duct sign, right? So double duct sign is seen in pancreatic cancers. Chale, moving to the next one, question number 19. Okay, again a very interesting question. Now, here also we have an elderly female, already have ulcerative colitis, presents to you with onset of vague epigastric pain, jaundice is already there. She denies any weight loss, lab results, WBC is slightly elevated, 4 to 11 is normal, 12 we say, bilirubin is on borderline elevated, CT scan subsequent ERCP shows irregular narrowing throughout the intrapancreatic common bile duct. No masses are identified on endoscopic ultrasound. What is the initial treatment of choice for this patient, right? So what do you have? I have a elderly female, right? Known case of ulcerative colitis. These are the two important data that I have. Then you have patient is having jaundice, patient is having vague epigastric pain. Usually jaundice with pain should go into liver pathologist, but here you will see the lab results signifies, because in cholecystitis, or I would say in obstructive jaundice, the WBC count is slightly more higher than this one, so it is only 12,000. Subsequent CT was done, and here you say there is narrowing through the intrapancreatic common bile duct. So basically it is the pancreas compressing the common bile duct, right? Now when you look at the CT image also, I am able to see the pancreas here is pretty much edematous and it is thickened and become very large. This is also called as the sausage shaped pancreas. Now, sausage-shaped pancreas is characteristic of autoimmune pancreatitis. It is characteristic of autoimmune pancreatitis. Why I'm saying autoimmune? Because ulcerative colitis is associated with autoimmune pancreatitis. So this could be a case of autoimmune pancreatitis where you have diffuse enlargement of the pancreatic gland, and it also compresses the common bile duct. That explains jaundice without elevating of WBCs, right? So what would you like to do? For autoimmune pancreatitis, the management is steroids only. So here the answer is going to be steroid. No surgery should be performed. It's an autoimmune disorder. No, why surgery to be done, right? Now, what all you need to know with for autoimmune pancreatitis? For autoimmune pancreatitis, usually it is seen between the age group of 30 to 70 years. It is more common in males when compared to females. That is very important. Remember, more common in males. Why? Because autoimmunes are more common in female when compared to males. This is one condition where it is more common in males, right? Again, it is associated with painless jaundice. Around 70% of the patient of autoimmune pancreatitis presents with painless jaundice, right? It is also associated with ulcerative colitis. Around 30% of the patients are associated with, I would say, ulcerative colitis. The characteristic image on CT that I just showed you is your sausage-shaped pancreas. Sausage-shaped pancreas. Your pathologist will tell you for autoimmune pancreatitis, there is elevated IgG4 class of immunoglobulins, very important, right? Another one is elevated anti-nuclear antibody levels, ANA, anti-nuclear antibody levels, and the management is going to be steroids. The steroids that we give is 30 to 40 milligrams of prednisolone for 7 days. This is the regime that we follow for autoimmune pancreatitis. Right? So this is a case of autoimmune pancreatitis. How did we pick up? Sausage-shaped pancreas with presence of painless jaundice and history of ulcerative colitis. These are three important pickup points for autoimmune pancreatitis. Right? Moving to the next question. Question number 20. Now, again, interesting question. We have 30 years old young female patient with dumbbell-shaped swelling that is soft, cross-fluctuant and painless. Where is it? In the submandibular region since 2 months. So submandibular region, cross-fluctuation, you can put your finger inside. So there will be swelling under the tongue and there will be swelling here. And it's a dumbbell-shaped swelling. You push from the tongue, the swelling will enlarge here. You push here, the swelling under the tongue will enlarge. This is nothing but a case of plunging ranula. This is a case of plunging ranula, right? Again, it confirms further by saying a thick yellow fluid was noticed, right? Which among the following is false? I have to look for false statement. Look for false statement. It arises from sublingual glands, correct. It's a plunging granula, correct. It's a mucous retention, correct. Cervical approach is now contraindicated. It is not preferred. Now we go for intraoral. So answer is D for Delhi. So it's a case of plunging granula, right? Okay, on to the next question. Question number 21. Okay. Again, we have a 58 years old male patient with HCC in the right lobe of the liver with largest measuring nodule of 5 centimeter with portal vein invasion, right? Bilirubin is 2.2, albumin is slightly less, PT is okay, ascites, no evidence of ascites of encephalopathy. What would be the next line of management according to BCS? So basically he wants us to know what is Barcelona criteria of liver cancer. BCLC stands for Barcelona criteria for liver cancer. Now, according to the Barcelona criteria, we have divided the liver cancers into 3 stages. We call it as the stage 0, number 1. Then we have stage A, B, and C as one category. And the last terminal category is called as the stage D category. We call it as the stage D category. Now, stage 0 are those patients where the child pug score is, or the class is class A, right? Child plug is class A. Here the criteria is, remember, it should have a single tumor. The size of the tumor should be less than 2 centimeters. It should be less than 2 centimeters. The portal vein should remain normal and the bilirubin levels, the portal vein and the bilirubin should remain normal. If the patient have a child plug class A with a solitary tumor less than 2 centimeters without involving portal vein and the bilirubin levels are normal, these are the patients which are ideal for resection. These patients can be taken for liver resection. They can be taken for liver resection. On the other hand, when do you call it as BCLC stage A? Stage A are those patients where you have a single, again, child plug classification is important. Here, child pug can be between A and B. So CPS can be class A or CPS class B. Both are acceptable. CPS class A and class B both are acceptable. Remember, it has to be a single nodule. It has to be a single nodule of size less than 5 centimeters or maximum of 3 nodules with size less than 3 centimeters. Single more than less than 5 or multiple, that means there are multiple means it should not be more than 3, but size should be less than 3 centimeters. Size should be less than 3 centimeters. Here we can have 2 categorizations where the portal vein and bilirubin is normal or the portal vein and bilirubin are abnormal. Now, if portal vein and bilirubin are normal, here we can go with liver transplantation, which is also described as the Milan's criteria. Milan's criteria is what you are seeing here. A single nodule, what is Milan's criteria? You should have a single nodule of size less than 5 centimeters, multiple nodules of size less than 3 centimeters, absence of portal vein involvement, and there should not be any extra hepatic spread, right? Absence of extra hepatic spread. If these are satisfied according to Milan's criteria, patient can be taken for liver transplantation. If it is abnormal, then we have to go with radio frequent ablation. Radio frequent ablation, that is RFI or RF, radio frequent ablation, radio frequent insemination, whatever is, RFA is a treatment here. If it is stage A, stage B will also have CPS A and CPS B, that is child plug class A, class B. Here you will have multiple nodule, that is more than 3, or size greater than 5 centimeters or size greater than 5 centimeters. The management which is preferred here is transarterial chemoembolization, that is TACE, right? For BCLC stage C, we have again CPS A, CPS B, that is child plug A or B. But here it is going to be an advanced disease. Advanced disease, that is involvement of portal vein. Until now the portal vein was spared. Now there is involvement of portal vein, and this is addressed with sorafenib. This is addressed with sorafenib. Stage D is CPS score C. It is considered to be a terminal stage. It is only best supportive care. It is only best supportive care to be offered. So this is what is called as Barcelona criteria for liver cancer management. According to this, if we imply on our question, we have a patient who has HCC with 5 centimeter with portal vein invasion. So 5 centimeter with portal vein invasion. Involvement of portal vein, right? A stage is limited. Involvement of portal vein with size around 5 centimeters, then the best answer would be sorafenib. So it is going to be C for Calcutta. Sorafenib will be the answer of choice, right? So what would be the next line of management? Based on BCLC, it is going to be sorafenib. Which among the following is included in Bouchard's triad? Bouchard's triad is seen in gastric volvulus. It is seen in gastric volvulus, right? Now, in gastric volvulus, what is going to happen is, normally if the stomach was present like this, there are two ways it can rotate. Number one is organoaxial, another one is atlantoaxial. If it rotates like this, or it rotates on its axis, that is the organoaxial and the atlantoaxial. Basically, when the stomach gets twisted, what are you going to expect? This is how the stomach is going to be twisting. Right, so this is how the stomach is twisted. In this, what will you see? Right, now patient wants to vomit, he'll not be able to vomit, so patient is going to have unproductive retching. He wants to vomit, unable to vomit because the vomitus is blocked here. So unproductive retching. Obviously, when the stomach is twisted, it will have vascular compromise, which is ischemia, pain. All foregut pain is localized to epigastric region. So patient is going to have epigastric pain as well. So presence of epigastric pain. And the last one, because patient have retching, he is not able to vomit at the same time pain. I would like to pass a Ryle's tube. The Ryle's tube will go and stuck here. It won't go any further. So inability to pass Ryle's tube. Inability to pass nasogastric tube. All three put together is called as the Bouchard's triad, right? So which is saying which among the following is included in Bouchard's triad? Bilious vomiting, not included. Ability to pass, no, it is inability to pass. Abdominal pain and abdominal distension. There is no distension, it is the pain, that is epigastric pain. Sorry, that is about Bouchard's triad and gastric volvulus. Question number 23, right? According to recently suggested a simplified system of European Hernia Society, a primary indirect inguinal hernia. Indirect inguinal hernia is nothing but I would say the groin hernias, or I could say the lateral hernias with a 3 centimeter size defect is classified. 1.5 centimeters considered to be one defect. 3 centimeters will become two defect, right? It is PL2. So the answer for simplified hernia society classification is C for Calcutta, PL2. What do you mean by this? Sir, what is this? Normally, according to hernia society, we divide the hernias into primary, that is first time appearing, or recurrent, that is operated and reoccurred. It is given as P, this is given as R. Then based upon the location, they are lateral hernias, which are the inguinal hernias. Then we have the medial hernias, that are your ventral hernias, epigastric and umbilical hernias. Lateral hernia also includes the lumbar hernias as well, right? Lateral hernias is given L as a prefix, medial is M. Femoral hernias are given separate, that is F. Then based upon the defect size, remember defect size is measured with respect to finger. It's a clinical scoring system. One finger breadth is taken as 1.5 centimeters, which is called as one defect, 1D, right? Now if you have a 3 centimeter defect, it is going to be called as 2D, right? So if you have a primary inguinal is nothing but lateral with a 3 centimeter defect will become PL2. as the classification, right? That is nothing but C for Calcutta. C for Calcutta. So we move to the next one, 24th question. Which of the following surgeries are best suited to treat? I'm talking about best suited to treat carcinoma tumor of bronchus. Okay. Now, a very interesting point about the bronchus carcinoids. When you look at the bronchus carcinoids, this is a trachea, these are the bronchus. Let's say it is going right across here. And let's say this is the lung which is present here, and these are the third generation of bronchus that you have. Now, let's say the patient have a tumor which is present at this particular location, right? Now, because it is having a tumor at this particular location, remember the bronchus carcinoids are of low malignant potential. The carcinoid tumor of bronchus are of low malignant potential. Now, because they are of low malignant potential, we do something called as local excision of the parenchymal tumor along with the lung parenchyma. This is nothing but your sleeve lung resection. This is nothing but your sleeve lung resection. So sleeve lung resection is removing a central tumor that is invading the major bronchus, right? Along with that, we'll also remove the lung parenchyma associated with the tumor and the lobe that is involved, right? It's an anatomical lobe. You remove the entire thing. This is called a sleeve lung resection. Those are not able to comprehend. In sleeve lung resection, we remove the central tumor. We remove the central tumor along with bronchus involved, or the not the entire bronchus, a part of the bronchus involved, the part of the bronchus involved. Along with that, we'll also remove the lobe in which the tumor is present. This is called a sleeve lung resection, right? So sleeve lung resection, in fact, becomes the surgery of choice for bronchial carcinoids, which is also called as bronchoplastic, called as the bronchoplastic lung resection. Bronchoplastic lung resection, right? So according to this question, which is best suited, the answer is bronchoplastic lung resection. That is D for day. Now the last question, which of the following statement about esophageal pressure topography? Esophageal pressure topography is nothing but high resolution manometry. It is high resolution manometry, right? So he's asking all of the following statements are true except, so we'll look for false statement, right? Now when you look at the high resolution manometry and conventional manometry, if this is the esophagus, this is a gastroesophageal junction. In a high resolution manometry, when we pass down a probe, this probe is going to have multiple sensors. In fact, the sensors goes as high as 36 sensors, and all these 36 sensors are placed at 1 centimeter distance, and they can measure the pressure sensitivity in both on like all two-dimensional images, right? So the circumferential and the parallel, both longitudinal and circular pressure topography can be performed. Hence, it is called as topographic pressure analysis. Conventional manometer had only 2 pressure sensors, and these pressure sensors were present 5 centimeters above the gastroesophageal junction and 5 centimeters below the gastroesophageal junction. That is how you will measure the pressure above and below the gastroesophageal junction. This is a conventional manometer and this is a high resolution manometer, right? Now let's look at the statements. With respect to high resolution manometer, that is esophageal pressure topography, pressure sensors are no more than 1 centimeter apart is true. They are 36 centimeters radial and longitudinal is correct. Allowing 3-dimensional spatial pressure is also correct. It is placed 5 centimeters above and below. This is conventional manometer, not high resolution. So answer is D for D, right? So this is all you should know in the context of esophageal pressure topography.